This is the abbreviated version, and this does not include the physical principles of the production of various artifacts and so on. And if you are really interested, then I will give you the link to that particular talk. Now, lung ultrasound has always been a fascinating thing. It's traditionally people think that you can't do ultrasound on the lung, and the reason for that is because air is the biggest enemy of ultrasound, and therefore when you have air, when you have normal aerated alveoli, you cannot actually see actual lung tissue. And whenever you see lung tissue, that itself is abnormal. It means that the air has gone out of the alveolus and therefore it's disease. So for a long time people never used to do lung ultrasound. However, the artifacts were found to be quite reliably reproducible, and therefore this beautiful artifact analysis has now become the art of lung ultrasound, and this is now extremely reliable and consistent. What is called a 10 region technique. Okay, and the what you do is, just like with any form of ultrasound or imaging, you just pick and choose a few representative areas that you think will give you the entire lung. Okay, so for the right lung, as an example, this being the red line here is the diaphragm, and you have the liver here. You choose one area in the anterior part of the lung, in the upper zone, somewhere above the nipple or near the nipple, and somewhere below the nipple. The side along the mid-axillary line at the level of the nipple and below the nipple, and then one point really basally posteriorly, which is called the Plapp's point, and that is considered to be the base, and that is adjoining the diaphragm. Okay. Now people ask me all the time, which intercostal space constitutes the right anterior upper zone, and there is no such thing. You can just keep the probe anywhere here, anywhere along this zone, and in fact, if you keep your probe at the second intercostal space and you get one particular finding, and along the fourth intercostal space you get a completely different finding, please scan both areas, because this whole thing here, it assumes that there is a reasonable homogeneity. If there is any heterogeneity, immediately you have to scan the heterogeneous areas and get those pictures as well. As a minimum, these are the five zones in each lung. So 5 plus 5, 10 zones for the whole of for both the lungs. At each location, what you do is you take the probe and you place it with a probe marker facing the 12 o'clock position. So it's a longitudinal orientation. The patient will be in the supine position. You keep the probe marker facing the 12 o'clock position. So here, okay. Then what you do is you identify, you place the probe in an intercostal space. How do you identify where the intercostal space is? By this. So you identify one rib, which is the bright hyperechoic curvilinear structure, and another rib, which is the bright curvilinear structure. Now, because the probe marker is facing the 12 o'clock position, this means that here the screen marker, that this area here must be superior and this here must be inferior. Okay. Now, when you use the abdominal probe or the curvilinear transducer, the default is that the screen marker will be at this location, which means this becomes superior and this becomes inferior. So long as you know the orientation, it doesn't matter. So if you've listened to the physics talk, then that will be clear. In this particular image, this is superior and this is inferior. Okay, and this is therefore the superior rib. This is the inferior rib. You can see the more prominent than the ribs, you can actually see the shadowing, the black shadowing coming from each rib, and this is called the acoustic shadow. Okay, so this is how you identify the ribs, and the space in between is called the intercostal space. Okay, so this area is actually the intercostal space here. So superior rib, inferior rib, each with its own acoustic shadow, and the space in between is called the intercostal space. And remember, the intercostal space must always be in the middle of the image of the screen. Okay, now if you can use your imagination, this thing here looks like a bat. It's a flying bat with the wings spread across. So this is called the flying bat sign. Okay, so these are the wings of the bat. The acoustic shadows are the wings of the bat, and the intercostal space here is the body of the bat. Immediately deep to the ribs, so immediately deep to the ribs, you have a bright echogenic hyperechoic line which is curvilinear. This is about half a centimeter deep to the rib, and this is called the pleural line. Okay, the star here, this is called the pleural line, and it's called 0-1, or the first hyperechoic line. This is the pleural line. Okay, then you identify that, and then what you will find in a normal lung is, before that, if you in real time, or when you're storing it as a video, you will find that this pleural line will slide from cephalad to caudad, from one side to another on the screen, in a sort of a very shimmering ants marching motion. So it's as if millions of ants are marching. Okay, I'll show a video of this. That's called the pleural sliding, and that's a normal finding. You always have to identify that. Okay, and in a normal lung, deep to that, you will find parallel lines called A lines, and in an abnormal lung, you will find other artifacts. You may find B lines, etc., which we'll cover later. Okay. Now, one important note about the base. The base must be really, really, really posterior and basal, which means that you actually have to keep it in the posterior axillary line. You should be able to see the diaphragm. See, can you see the diaphragm here? And you should be able to see the liver. Okay. Now, and the part on the screen that is superior to the diaphragm, or cephalad to the diaphragm, is the lung. Okay, see here that the pointer is on this side, which means this is cephalad and this part is caudad. So that's the diaphragm. This structure here is the liver, and the structure superior to the diaphragm is the other lung. This is the basal view. However, if you notice this, you can actually see the kidneys inferiorly. And in fact, almost 73/4 of this entire image is filled with the abdominal contents. This is actually not a lung ultrasound, this is an abdominal ultrasound. So a proper basal view, however, will have the abdominal structures more inferior or more caudad, and you have to have more of the lung structures. But essentially, you have to see the diaphragm and the lung as well. Okay, so this is a good basal view. Okay, so here you can see the diaphragm, you can see the liver, but the bulk of the image is actually filled with thoracic structures, and in this instance you can see a pleural effusion, and you can see lung that is collapsed in a wedge-shaped fashion. Okay, solid lung. But this is an example of a good basal view. Okay, now once you've identified all this, once you've identified the 10-point technique and you've kept the probe, there are 6 main findings or patterns that you have to notice. First, as I said, you have to always identify the pleura. That is a real structure. Once you identify the pleura, you have to evaluate whether or not this pleura is sliding from superior to inferior, cephalad to caudad or not. Okay, so pleura and pleural structure, pleural sliding are two very, very important things, and both of these are real structures. Then you have you may have some artifacts. In a normal lung, you have what is called the A-line artifact. Sometimes if you have fluid in the lung, you can have B-line artifact. Then, if you have a loss of lung aeration, so the alveolus has lost air, then the lung almost becomes a solid tissue like the liver, and this is called hepatization. Again, this can be seen as a real structure. Okay, and within that hepatized lung, you can have what are called air bronchograms. You can have something called C lines, and these are all structures that you can see in deaerated lungs. Then, just like we saw in the previous picture, you can see a black structure alongside in the pleural space, which is the pleural effusion. Once again, these are real structure. A patient can have any combination of these findings or patterns. To restate what I said before, the combination of pleural sliding plus A lines is strong evidence for normal lung at that probe location. Okay. Patterns in abnormal lung could be any of the other things, the other 6 patterns that I talked to you about. There are 4 clinically relevant abnormalities that are important, and a few of them in the parenchyma and a few of them in the pleura. In the parenchyma, you can either have extravascular lung water, which is otherwise called pulmonary edema, or you can have collapse consolidation, or you can have both, of course. Okay, so pulmonary edema and atelectasis are consolidation. In the pleura, you can have a pleural effusion and you can have a pneumothorax. So these are the most important abnormalities that you're interested in. And let's see how lung ultrasound can be used to identify these 4 pathologies. First of all, the easy bit is when you have collapse or consolidation, it's essentially a lack of air in the lung. Okay? What happens when you have a lack of air in the lung? You will have hepatization or solidification of the lung. This will now just become like tissue, like normal tissue. And this can therefore be seen as a real structure, both atelectasis and consolidation. And this is how it looks like. Okay? When you can see, so this classically illustrates it. This is a basal view of the lung. That's the diaphragm, that's the liver. Okay? And on superior to the diaphragm, normally you should have aerated lung, but what you have here is just a hepatization of the lung. And can you also see a lot of bright echogenic lines? And in fact, a long line here. These are all called air bronchograms. This is a classic example of collapsed or consolidated lung. Okay, another example, liver, diaphragm, and this is an example of a collapsed lung. Okay, this I don't know where what I'm seeing, to be honest, because this could either be I think this is the hepatized lung with air bronchograms within it. I don't know where I am. I can't see the liver or anything in this instance. Okay, so this is a classic example of solidification of the lung called hepatization, and within the hepatized lung you can have bright echogenic spots called air bronchograms. The additional evaluation of air bronchograms depends on whether the air bronchograms are moving with respiration or remaining static despite the patient's respiration. If they move with respiration, they're called dynamic air bronchograms, and if they don't, they're called static air bronchograms. What dynamic air bronchograms mean is that particular hepatized lung is actually communicating with a patent bronchus, and that means that it is not collapse, it is not atelectasis. This is highly suggestive of consolidation, but it only has a specificity of about 60%, which means that it's a flip of the coin. You can have you don't often see this, so you can easily identify air bronchograms, but to make the differentiation between static and dynamic air bronchograms is much more difficult. Then the second problem, which is a real structure, I'm jumping from the parenchyma to the pleura now, and this is the pleural effusion. Very easy to identify. All you have to do is to identify a black space within the pleural cavity. Okay, so this is an example. This is an image that we saw before. Liver, diaphragm, and above the diaphragm, rather than having lung tissue, you have a black anechoic structure. Okay, here. This is the pleural effusion. And if you notice, this structure, which is a wedge-shaped structure, is a collapsed lung within the pleural effusion. So the pleural effusion has collapsed the underlying lung. You can't actually, it's so dense, it looks just like a solid structure. You can't actually see any air bronchograms in this instance. Okay, so it's an anechoic area surrounding the lung. When you see this, you have 2 descriptions you can do. One is quantity, we'll come to that in a minute, but importantly the quality. You look at the echogenicity of this anechoic structure, and if it's absolutely black, it's called a simple effusion. On the other hand, if it's like this, if it's loculated or if it's septated, filamentous structures, then you can call it a complex effusion. Now this is a classic example of a complex empyema. Just see how within that anechoic structure you have almost a honeycombing, okay, and very thick. These are loculated effusions, and this is an example of if you put a needle into it, you are going to get pus, almost certainly. Quantitative. A lot of people want to know how much effusion am I dealing with. Okay, this is a very arbitrary estimate. There is no science behind this. First of all, what you do is you keep the probe location at the posterior axillary line, and rather than having a longitudinal orientation, you turn the probe and have it in a transverse orientation at about the 3 o'clock. And then identify the separation of the parietal pleura from the visceral pleura. Okay, so this is the edge, this is the superficial edge of the pleura. Then you have the pleural effusion, the black space here, and then right at the end you have the lung beginning, and then this is the visceral pleura, and the maximal separation you identify in number of millimeters and multiply this by 20, and you will get the approximate effusion volume in milliliters. So the maximal separation times 20 will give you the number. Will give you, in this instance, if this is about how many about 10 to 12 centimeters. Sorry, which is about 100 millimeters. 100 times 20 is 2000 ml or 2000 milliliters. So now the next clinical syndrome is that of pulmonary edema or extravascular lung water. Okay. And the ultrasound appearance of pulmonary edema is by the artifact of B lines. So far we have seen A lines, which are artifacts. We've seen consolidation or collapse, air bronchograms, and pleural effusion. This is the final thing, which is B lines. There are 6 mandatory characteristics of B lines. 1, they are vertical lines. Second, they originate from the pleural line. They always originate from the pleural line. They move with lung sliding. So when the lung moves like this, the B lines will also move along with that. So the B lines which are here will also move like from one side to the other. And when the B lines are present, just under the B line, you cannot see the A line at all, because the B lines are so bright that the A line over which the B line is present, along the path of the B lines, you cannot see any of the A lines. You may be able to see a little bit of A lines between 2 B lines, but on the B line itself, or just under the B line, you can't see the A lines. So they erase the A lines. The other important thing is that they extend indefinitely, all the way throughout the depth of the field without being erased. Unlike some other lines called Z lines. Z lines are completely inconsequential lines. They originate from the pleural line, but they just start from the pleural line and end about 1 or 2 centimeters. Please remember this, because a number of my trainees have made the mistake of mistaking Z lines for B lines. Z lines may start from the pleural line, but they will end very shortly. They will not go all the way down like B lines. Z lines have no clinical significance whatsoever, whereas B lines mean that there could be some extravascular lung water. Now, B lines are not always pathological. Even you and I could have B lines. So they could be normal. So how do you differentiate between a normal B line and an abnormal B line? Or a pathological B line, sorry. In any one intercostal space, you may have up to 3 B lines. Anything more than 4 B lines are completely abnormal. Then, the more important than that is the distribution. You and I, our B lines are going to be more dependent. We'll have our B lines somewhere along the base of the lung, just along the diaphragm. However, if you start seeing B lines in spaces, a couple of interspaces above the diaphragm, even if you only have 1 or 2, you start having to take them seriously. Okay? So a number of my trainees have noticed 1 or 2 B lines in the lung apices. And they say, Arvind, you told me up to 3 B lines are fine, so I said this is fine. My response to them is, you don't really have B lines in the apices at all. Okay? So when you have 1 or 2 in the apices, just scan around and make sure that you don't have a consolidation or a collapse, because remember that B lines are not always cardiogenic pulmonary edema. B lines can be associated with any form of lung water, including interstitial lung water, inflammatory lung water associated with the pneumonia. So just scan around and make sure that you're not missing air bronchograms or a consolidation. When you have just 1 or 2 B lines along the diaphragm, forget it. That's normal. You and I can have it. Now, these are all examples and they all have nice teaching points. First of all, the white line that comes up here is the B line. Okay. The white vertical line here. Here, if you count, you have at least 3 or perhaps even 4 B lines. They're all coming from the pleural margin. They're all coming here from the pleural margin. And they go all the way down. And when you notice that there is no decrease in the brightness at all from superficial to deep. And along the path of the B line, you find that the A line gets obliterated along the path. So you can see the A line in between the B lines, but in that path of the white B line, you can't see the A line. So this is the classical example of B lines coming from the pleura, going down all the way and not attenuating at all. And here, in this instance, the patient has at least 3, if not 4 B lines. Okay. This is in the right mid-axillary upper zone for this patient, so just under the clavicle on the right side. The same patient, if you go down a couple of interspaces, you find that you have only 1 B line somewhere near the heart, somewhere in the lower zone, right anterior lower zone. This is a little bit unusual, and in this instance, the patient had a right upper lobe pneumonia, and that's why you have more B lines superiorly than inferiorly. Okay, so but once again, concentrate on the B line itself. Again, it's coming from the pleural line. It's going down all the way. It's not attenuating, but in this instance, you only have 1 B line in this intercostal space. Okay, this is a different patient, and this is an illustration of how many you can count a large number of B lines, 1, 2, 3, 4, at least 4 or 5. Okay, B lines. And then another patient again, it looks like there is only 1 B line. But look at the size of that, the thickness of that B line. It's big and fat. And same thing here. It's a big, fat B line, even though there only seems to be 1 or perhaps a second B line just here. Okay. This particular B line here and this particular B line here in a different patient, they're big and fat. These are called confluent B lines. And you have to count them as more than 3 or 4 B lines, and that's significant. Another very important concept is that B lines are semi-quantitative. Okay. Now, what do I mean by semi-quantitative? The more the number of B lines in a particular intercostal space, the more the amount of lung water. So if you only have 1 or 2 B lines, it means a very tiny amount of lung water. When you have 7 or 8 or 10 B lines, or in fact, when you have a condition where you have a big, fat, confluent B line that extends from the superior rib to the inferior rib, all across the intercostal space, that means that is alveolar edema. Okay? And that is a lot of lung water. So B lines offer an approximate quantitation. There's nothing scientific about it. You can't say that there's 50 mils or 73 mils of water. It just means that there's a lot of water. The more the number of B lines, the more the amount of lung water. And in fact, you can see this in a clinical situation. If you give somebody with pulmonary edema, if you give them furosemide, and after some time the patient gets better, or you put them on CPAP with cardiogenic pulmonary edema, you put them on CPAP, you'll find that half an hour or 1 hour later, the number of B lines have gone, reduced. Second, the B lines which were everywhere, including the lung apices, now you find that the lung apices are dry. There are no B lines there. And in an extreme thing, some of the cardiology thing, people say you do a 28 zone approach and you can quantify the B lines, and then you can say in the morning 16 zones were full of B lines, now only 4 zones have B lines. That's an extreme. You don't have to do that. You just have to just do 5 plus 5 and you'll get a reasonable. Now, B lines, what are the conditions that can produce extravascular lung water or B lines? It can be both cardiogenic pulmonary edema, or it can even be non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema will be classically associated with transudative water. Okay? So, for examples, you can have cardiac failure, renal failure, liver failure, just fluid overload from excess fluid infusions. All of these are extra fluid in the lung, and if you give them furosemide or if you dialyze them or if you put them on CPAP, this water will just go away. Okay. On the other hand, you can also have non-cardiogenic pulmonary edema due to inflammations. For example, you can have pneumonias, ARDS syndrome, so diffuse infections, pancreatitis, TRALI or transfusion-related lung injury, or pulmonary contusions, even malignancies and interstitial fibrosis. All of these will be associated with lung water that is pathological, which does not really go away. So if you give them furosemide, they're not suddenly going to improve. Okay. So any of these conditions can be associated with B-lines. Another very important thing is the diffuse versus focal interstitial syndromes. When you have a diffuse interstitial syndrome, you need to have B-lines in both lungs in at least 2 lung areas or 2 lung zones. On the other hand, focal B-lines will have either unilateral B-lines or they will have less than 2 zones involved bilaterally. And classically, the any diffuse process that involves both lungs is going to be either related to cardiogenic pulmonary edema or a diffuse inflammation such as interstitial pneumonias or interstitial fibrosis. On the other hand, focal extravascular lung water is typically inflammatory, related to localized conditions like pneumonias or contusions or malignancy. When you have a B-line pattern, not just diffuse or focal, another important thing that you have to do is to look for further evidence of inflammation. Okay. Now this is from the same patient, left base and right base. Now look at the right base first. Okay. It has a B-line pattern, but look at the nature of the pleura. It's absolutely pristine. It looks thin and nice. This is an example of a B-line pattern usually associated with transudative causes, non-inflammatory causes, such as just plain fluid. And if you give them a diuretic, this fluid is likely to go away. On the other hand, look at this. This is the left base. And here, look at the pleural margin, the pleural line. It is quite thickened and it looks nodular. This is an example of most likely inflammatory fluid associated with inflammatory changes of the pleura. So lung ultrasound can actually differentiate between so if you look carefully, when you can look for all of these subtle findings on lung ultrasound, which can be a good pointer towards the etiology, not just the presence or absence of lung water, but actually the potential cause for the lung water. At least it will tell you whether it's an inflammation or not, and then it is up to you as the clinician to determine whether the inflammation is due to something like an infection, pulmonary infarction, or due to interstitial fibrosis, something like that. Now, these are other examples of a thickened pleura. Okay, it's from the same patient. This is a patient, left anterior upper zone, left anterior lower zone. So it's a midclavicular line. This is just under the clavicle, whereas this is below the heart or somewhere near the heart. Okay. Firstly, the pleural line above in the midclavicular line looks thin and nice, whereas if you go a few interspaces below, it is mildly thickened and nodular. And you can see that on the right side, this patient has an absolutely thin and pristine pleura. So this patient actually had a left lower zone pneumonia, and you can see that from the difference in thickness of the pleural line that on the left side, the pathology is mainly seen in the left anterior lower zone, where it's nice and thick, where it's quite thick. It's not quite normal, but it is better here under the clavicle. But on the right side, it's absolutely pristine. Now, in summary, normal lung has a combination of pleural sliding plus A lines. Abnormal lung without air can actually be seen as solid tissue, and they may have, with or without air bronchograms. And this is produced by either atelectasis or consolidation. Pleural effusion can be seen as an anechoic space within the pleural cavity. Extravascular lung water, and ultrasonologically we call it interstitial syndrome, is manifested by B lines, and as I said before, it can be diffuse or focal. And finally, you can have a pneumothorax, which is a special entity, and we'll cover that in a minute. Is about pattern analysis. So the whole thing with lung ultrasound is when doing a lung ultrasound is actually not difficult at all. It's a technique where getting the images is easy. You just keep the probe on an intercostal space. You identify the flying bat sign with the superior and the inferior rib and the acoustic shadow, and all you have to do is you get something in intercostal space. The difficult or challenging thing is about identifying the pattern that you find in that intercostal space and making sense of it. So there will be a lot of repetition in the subsequent part of this talk with the previous slides. But bear with me, because this repetition is just to reiterate how you go about identifying the pattern and making a clinical correlate from your ultrasound findings. So firstly, normal lung. Normal lung is a combination of pleural sliding plus A lines. The plus or and is very important. If you don't have pleural sliding, or if you don't have an A-line pattern, it is not normal lung. You have to have both to call it a normal lung. At that probe position, remember, this is the 5-zone technique or 10-zone technique. In each area, in each zone, you have to have a combination of pleural sliding plus A-line pattern to call it normal at that location. Abnormal, therefore, is either a lack of pleural sliding and/or an artifact pattern that is different from A lines, and/or you find something else like a collapse or a consolidation or a pleural effusion. If you find either that the pleura doesn't slide, or you have a different A-line, a different pattern of artifacts, or you can actually see the lung or actually see some real structures such as the pleura, that means it's abnormal. So the first finding of significance is the lack of pleural sliding. And when you have lack of pleural sliding, this is such an important finding that you always have to confirm it. If you have presence of pleural sliding, it automatically rules out a number of differential diagnoses. In particular, it rules out a pneumothorax. On the other hand, if you do not have pleural sliding, you'll have to think of other differential diagnoses. Therefore, always confirm it. What my recommended methods of confirming it are: firstly, zoom into the pleura using the existing probe, so the curvilinear probe or the cardiac probe with which you're doing it. Zoom in all the way to the pleura by reducing the depth of the field to just deep to the pleural line, and very carefully observe whether there is lack of pleural sliding or whether there is minimal pleural sliding. Even if there is a small amount of pleural sliding, that is enough. I always advocate changing over to the linear probe when you're scanning the pleura superficially, because the resolution is excellent. The next thing is use M mode to differentiate between the stratosphere sign and the seashore sign, which I'll demonstrate in a minute. So this is an M mode picture of the seashore versus the stratosphere or the barcode sign. When you have normal lung, what you do is when you put an M mode across the intercostal space, this is the picture that you get. This bright line here is the pleural line. And people who do not know M mode, this is the y-axis and this is the x-axis. Okay, the x-axis is time and y-axis is just the representation of the ultrasound along this line. Okay, so as I said, this is the pleural line, and the structures that are superficial to the pleural line are the chest wall structures, and the structures that are deep to the pleural line are the artifacts coming from the lung. Okay, if you see the chest wall structures, they don't move at all. There is no movement of the chest wall structures. There's no change at all with time, and that's because they remain static. On the other hand, the structures that are deep to the pleura, which is the artifacts coming from the lung, you can see how they have a granular or a wavy pattern. Okay, this is called the sea shore. So you have the sea and the shore. This doesn't move, and this moves. When you do not have any pleural sliding, what you find is that that's the pleural line here. Okay, these are the structures superficial to the pleural line, and they're not moving at all. But the structures that are deep to the pleural line are also virtually constant. Can you see how they're not moving at all? So if you pick this line here, just notice this, and there's no granular up and down movement. You can just trace a straight line all through. And this is an example of what is called the barcode sign or the stratosphere sign. Okay, and this is an example of no pleural sliding or absence of pleural sliding. And also, you can also see one big difference between the image quality with the vascular or with the curvilinear or the abdominal probe. Image that you get is quite pixelated. See how beautiful the resolution is with a linear probe or the vascular probe. That's why I advocate for the superficial structures such as the pleura. I advocate using what are the causes of absent pleural sliding? Now, pleural sliding means that you're not able, there is lack of visible lung movement. And this can occur either because of lack of lung movement, so the lung is not moving at all, and that's why you're not able to see it, or there is lung movement, but it's so subtle that you're just not able to see it on ultrasound. Okay. Now, when do you have no lung movement at all? When you have complete collapse or atelectasis, when the patient is breath holding or is apneic. In fact, I'll recommend this to you. You keep the probe on yourself, on your own intercostal space, and you stop breathing, and you'll find that you have a barcode sign or a stratosphere sign, or you'll have no pleural sliding. Then, when you have very severe hyperinflated lung like asthma, so it's a big alveolar, distended alveolus, which is just not moving at all. When you have low tidal volume ventilation, high frequency ventilation, or ECMO, and when you do not have, when do you have lung movement but you're not able to see it? Example for this is a pneumothorax. So the underlying lung is actually expanding and relaxing, but because of the air in the pleural cavity, which is static and not moving, you think you can't see the pleural line at all. Okay. Now, how do you differentiate between when somebody is breath holding or is apneic, or when you have when you have absolute lack of ventilation? Sorry, when you have a lung that is when you have lack of ventilation or hypoventilation from low tidal volume ventilation or so on. How do you differentiate that from something like a pneumothorax? There's one important finding called a lung pulse. And this is something that is best seen on the M mode. So once again, you have the M mode line of sight that is in the intercostal space, and this is what you're seeing. Okay, you have the structure superficial to the pleura. This is the pleural line here, the bright white line. Okay, and these are the structures deep to the pleura. And if you see the structures deep to the pleura, let's pick this line here. It's not moving at all with respiration. Okay, not moving at all with respiration right through. So there's no up and down granular wavy movement like that. Okay. However, what you can see, can you see these vertical lines periodically? Okay. Now this is called a lung pulse. So these structures here, this is called a lung pulse. And what is this due to? This is because these are because of transmitted pulsations from the cardiac pulse. So as the heart fills up the pulmonary capillaries and it fills with blood, it agitates the alveolus in a pulsatile fashion, and that's what you're seeing. The fact that you're able to see a lung pulse means that your ultrasound beam is actually penetrating deep to the visceral pleura, and you are actually able to see the lung itself. Okay, this effectively rules out a pneumothorax. Now, The next. So this is a patient with very severe asthma, which illustrates reduced pleural sliding due to reduced chest expansion. What you can see here is that there's hardly any expansion, up and down movement of the chest, even when you zoom up in the left anterior upper zone. Even when you zoom up, there's hardly anything. But clearly, you can see that there is pleural sliding. If you zoom up all the way to the pleura, you can see that there is pleural sliding. Okay, when you put an M mode, things get a little bit confusing, because what you can see here is you can see the seashore sign, which is consistent with normal pleural sliding, but all of a sudden it changes its pattern and it almost resembles a stratosphere or a barcode sign. The reason for this is that the patient is holding her breath. Her respiratory rate is set so low on the ventilator that they're essentially apneic. But if you pay attention, you can actually see pulsations. This. She has a lung pulse. Okay. So when you have patients, so the important thing is that when you have an absence of pleural sliding, you have to go and look for other import. First of all, you have to confirm by zooming all the way up whether or not there is a problem, whether there is pleural sliding or not. And then you also have to do other things, such as looking for a lung pulse or what the underlying pattern of the lung artifacts is, etc. So these are other examples of reduced pleural sliding. So this is a patient where, left anterior upper zone, where you can hardly see any pleural sliding at all. But when it is present, but it's difficult to differentiate this between accessory muscle use. Look at the ribs. The ribs are moving as well. Okay, and it's a nice zoomed up view of the pleura. I'll probably go for a linear probe next. But here what they've done is they've done an M mode, and the M mode clearly shows a seashore pattern with lung pulse. So this is not this. It's pleural sliding is present but reduced. Then this is a patient with a left lower zone. So this is somewhere near the left base, not quite the left base. It's actually the same patient, and here you can see clearly reduced pleural sliding, but you can see the B lines, and that automatically rolls out a pneumothorax. And what you have to do is you now have to scan widely in this area, looking for evidence of collapse or consolidation. Then a few other examples of reduced pleural sliding. So this is the right mid-axillary lower zone, right anterior lower zone. So in the mid-clavicular line in the lower zone, what you can see is, first of all, there is pleural sliding, but the chest expansion is significantly reduced. And the other thing that catches your mind is the number of rib spaces that you can see. So that's one rib, second rib, third rib, and perhaps a fourth I can't see. So clearly this patient has a loss of lung volume due to atelectasis. Okay. And then in the same patient, if you now go Cephalad and scan the mid-clavicular line above in the second or third intercostal space, so the right anterior upper zone, you have clearly here you can see pleural sliding. Once again, you can see a number of rib spaces. So the patient has had a loss of lung volume, but you can see pleural sliding. And when you put an M mode on that, you can clearly see a nice seashore sign, which is consistent with normal. Now, this brings me to the special case of the pneumothorax. And this is something that a lot of us are interested in. A pneumothorax it presents with an ultrasound pattern that has a lack of pleural sliding. And therefore, every single time you have a lack of pleural sliding, you must rule out a pneumothorax. Now, what is the ultrasound pattern of pneumothorax? It is a lack of pleural sliding plus an A-line pattern. But all of us know that this can be seen in patients with apnea, for example. So when somebody's lung is not, or endobronchial intubation, any cause where there is no pleural sliding because of lack of aeration of the lung can produce this. So a pneumothorax can definitely be ruled out by any ultrasound finding that arises from deep to the pleura. Okay, so when you see something that can only come from subpleural structures, for example, if you have any of the lines that we talked about, B lines, C lines, Z lines, whatever, or if you actually can see the lung underneath with air bronchograms or consolidation or collapse, then clearly the ultrasound beam is going beyond or deeper than the visceral pleura, and therefore you cannot have any pneumothorax in the parietal, in the space between the parietal and the visceral pleura. Okay? Therefore, if you find anything that can only come from subpleural structures such as these, that rules out a pneumothorax. But ruling in a pneumothorax is more tricky. And just before I go to ruling in a pneumothorax, I just want to make the point that the presence of a pleural effusion actually does not rule out a pneumothorax, because you can still have patients with a hydropneumothorax with a pleural effusion as well as air. So that's a separate thing. Now, so going back, ultrasound is excellent at ruling out a pneumothorax, but in order to rule in, to confirm the presence of a pneumothorax, there is only one pathognomonic finding, and that is called a lung point. And this is something important, and it's a bit tricky to get. So let me go in a little bit of detail. Now, the basis of the lung point. This is the trachea, that's the lung, and that red point is the visceral pleura. Okay, normally the parietal and the visceral pleura are both very closely stuck to each other, and therefore, and they're sliding on top of each other. There's little or no air at all, and therefore you should be able to see the alveoli just underneath the visceral pleura. But what happens when you have a pneumothorax, which is the yellow thing here? Let's put a few ribs and the sternum, okay? And now you're doing a lung ultrasound, and you keep the probe somewhere here. Now this probe is in the midclavicular line. It's over normal lung in the intercostal space. So this intercostal space here has normal lung. So you're going to have a normal A-line pattern plus pleural sliding. Then you take the probe and keep it on the superior space. Once again, normal lung here, and therefore you're going to have A-line pattern plus pleural sliding. Next space, once again, normal lung, A-line pattern plus pleural sliding. What happens if you keep it here? When you keep the probe here, now this probe is now at the interface between the normal lung, which is here, and the pneumothorax. So what you will find is that in this space, you will find when the patient takes an inspiration and the lung expands, the entire lung will come under the probe, under the transducer, and you will find pleural sliding. But when he expires and the lung markings go, and the lung collapses towards the hilum, it will be replaced by the pneumothorax, and therefore you won't have pleural sliding. So you'll have this intermittent presence and absence of pleural sliding. Okay. Now, another beautiful way of demonstrating this is if you actually keep a probe such as a curvilinear probe with a wide width somewhere here, and you try to get more than one intercostal space in the same view. Okay, so if you have this intercostal space, the inferior intercostal space as well as the superior intercostal space, what you will find is that in the inferior intercostal space you will have pleural sliding all the time, whereas in the superior intercostal space, you may not have pleural sliding. And that point is therefore called the lung point. The next video is a beautiful illustration of that. So watch that video and you will know, and it's actually demonstrates really well the technique of obtaining the lung point. Now, firstly, can you make the depth a little bit shallower, please? Because the pleura is a superficial structure, so you don't need anything more than, say, 5 to 8 centimeters. Just see one pleural line, one A line. So reduce the depth so that you have one A line. The first A line, no, that's the pleura. Where's the first A line? Yeah. Oh, right, okay, fine. So now go right on top, go to the apex of the lung. Good. Now tell me if you have, and then center it in such a way that you can see more than one intercostal space. So you can compare, the trick with lung point is to compare the superior versus the inferior intercostal space
Yep.
for the pleura. So where's the superior, and can you point out where the superior intercostal space is?
So that'll be the superior.
Okay, so
And the inferior.
tilt it, so you now have this in the middle of the probe, or of the screen. Can you tilt it in such a way that this intercostal space goes off to the inferior edge, so that you can see more of the superior? Beautiful. Okay. Is there pleural sliding superiorly?
I can't be sure here. Doesn't look like it.
Okay, just slide the probe up and be sure. Okay, are you now convinced? Is there pleural sliding?
Pretty sure there isn't.
Okay.
I could
How
confirm
can you
with
confirm?
I can confirm with a
No, put an M mode on this. You can. I know you can do a linear probe, but put an M mode on this and look for the barcode sign
okay.
or the stratosphere sign. That's a nice stratosphere sign.
Yep.
Okay. Okay. Take the M mode off. Now go back to 2D. Keep the probe back and have two intercostal spaces. Good. Now keep sliding the probe one intercostal space by one by one, and keep looking for whether there is pleural sliding. So wait about 5 seconds. Is there pleural sliding?
Currently not.
Okay, keep going down. Next intercostal space. Can you see any? Okay. You can now see 3 intercostal spaces there. Can you see any pleural sliding?
I can see some movement into the inferior, so I might just get
Okay. Now
Dave,
what you can do is,
yes.
why don't you put M mode through the superior space and then the inferior space? So move the beautiful. Put M mode. Barcode. Now the inferior space. Just shift it to the inferior and see what happens. What's that?
So as you can see, there's a seashore sign here.
Okay.
And stratosphere.
So go back to 2D and then get that interface where I think what's happened is you've slid laterally. So go back medially where you were. Okay. Now where's the superior space?
Maybe here.
Middle. The mid space.
Just
So in that.
mid-space,
Okay,
yeah.
there. Is there pleural sliding anywhere there?
No,
What about the inferior?
I can see sliding there.
Okay, go down a little bit, one more interspace down, and is now one more interspace down, beautiful. And can you see pleural sliding there?
Yeah.
Okay,
So
and
that will be it.
one more space down, and just hold on there. And can you see the pleural sliding there?
Yeah.
Yes. So therefore, the lung point is somewhere here, because that was the interspace. That was the location. In fact, probably lower than that, because now that's the lung point. Okay, that's excellent. So this now brings us to the further analysis of absence of pleural sliding. Please pay attention to this slide. It is an extremely important slide, which gives you a flow chart in patients where pleural sliding is not present, or where you think pleural sliding is not present. And the important thing here is it is designed to rule out the most important and life-threatening cause of pleural sliding, which is a pneumothorax. So the first step, whenever you think there is an absence of pleural sliding, the first step is always confirm that it's not present. Confirm that pleural sliding is absent. How do you do that? Just like we did in the previous case, you zoom up all the way to the pleura and always change the transducer from the curvilinear probe to the linear probe in order to look at the pleura and confirm that pleural sliding is absent. If you still think pleural sliding is absent, then the next thing is look for things that will rule out a pneumothorax automatically. And these are findings that can only come from structures that are deep to the visceral pleura. So the most obvious thing that becomes the most obvious kind of finding is a beeline pattern. If you find a beeline pattern, immediately it rules out a pneumothorax. And when you find a beeline pattern with an absence of pleural sliding, it is because the underlying lung is just not expanding, and you therefore have to look for causes such as severe atelectasis. You can also look for things like, the previous patient that we just saw, expiratory breath hold because of asthma and so on. But when you have an absence of pleural sliding with a beeline pattern, you start looking for severe atelectasis or consolidated lung, and you start looking for hepatization of the lung. Now, on the other hand, if you have an A-line pattern, your alarm bells should start tingling, because a pneumothorax is classically seen with an absence of pleural sliding and an A-line pattern. But there are other causes for this. And what are these causes? Firstly, you'll have to, and how do you rule them out? Firstly, what you do is you look for a lung pulse. If you have an A-line pattern plus a lung pulse, then it could be a patient who's apneic or breath holding, or a patient who is having such severe expansion of the hyperinflation of the lung, or reduced respiratory rates, or hypopneic patient such as asthma, just like in the patient that we previously saw. And these are all causes of absence of pleural sliding plus an A-line pattern plus a lung pulse. However, if you do not see a lung pulse, the answer is it could be a pneumothorax, and what you now do is you look for a lung point, okay, to confirm. Or in an emergency situation such as a cardiac arrest, severe desaturation, severe hypotension where pneumothorax is one of the differentials, you then empirically go and treat for a pneumothorax based on this ultrasound finding. Okay. So in summary, the pleural sliding, normal lung must slide. If, depending on the presence or absence of pleural sliding, you have a completely different diagnostic algorithm. So I always therefore will confirm the lack of pleural sliding before I proceed. The further analysis of the pleural sliding will depend on what type of artifact, whether it's an A-line pattern or a B-line pattern, and whether there is a lines of no significance whatsoever, or little significance rather. And these are C lines and Z lines. What are C lines? C lines are very, very similar to B lines, but so they're bright white vertical lines, okay, like this, which go all across, all through the depth of the field, and they erase the B lines, erase the A lines underneath, and so on. The only big difference is that the C lines do not originate from the pleural line. So if you see here carefully, this is the C line here. Okay, it's originating from here. The pleural line is here, and the C line is originating from just underneath the pleural line and not from the pleural line. So it's coming from here. This is because of air and water interface from collapsed or consolidated lungs. So whenever you see C lines, you always have to search for an underlying collapse or consolidation, and you have to search for air bronchograms. Are lines that have virtually no significance whatsoever. Okay, they're very similar to B lines. They originate from the pleural line, but unlike B lines, which go all the way down the depth of the field, and they erase the underlying A lines, the Z lines just die down very, very superficially. Okay, so if you look at this, that's the pleural line there, and can you see some white vertical lines appearing? They don't go all the way down, and they just die down very quickly. So even here along the depth of the field, you can't see any of those lines. Now the biggest significance of the Z line is that most of my trainees have got confused with B lines for this. They think that these are representations of pulmonary edema, whereas in actual fact the patient has an A-line pattern. Can you see the A lines here? And the Z lines have virtually no significance whatsoever. There's no pulmonary edema in this patient. Let's see some case studies now. This gentleman is a 64-year-old man with rib fractures. And the first two pictures, this is the left base, this is the left mid-axillary. These two pictures here are the left mid-axillary lower zone. And in these three, what you can see is there's hardly any movement of the lung that you can see. Here you can actually see a little bit of the liver. So this is probably the left base itself. And as you keep scanning cephalad, so this is now the left mid-axillary upper zone, these two pictures, it is now becoming clear why. This is a classic example of atelectasis. Can you see the number of rib spaces that you can see? Count here: 1, 2, and then 3. So in this small area, you have crowding of the ribs. You have got hardly any movement of this because of very severe atelectasis, but you can see here that there's a B line that's coming. Okay, so this is not a pneumothorax, this is not an absent lung sliding, or rather it's an absent pleural sliding, but because of hardly any movement. And then when you go one interspace higher or more superior, you can now see much better pleural sliding, okay, less crowding of the ribs. So you have significant basal atelectasis, and in the extreme, in the left base, in the actual left base, you can hardly see anything at all. Okay, now this is heavily collapsed lung which is not moving, and then as you go above, you can actually start seeing some crowding of the ribs, and finally this is where you have some pleural expansion. Now for the same patient, now we go to the right lung. Okay, this entire thing is the right lung. Now the first three pictures are the right anterior lower zone. So you're actually scanning somewhere along the midclavicular line, but anteriorly. Here and here are the lower zone, and here this is these three are the right anterior. This is the lower zone in the anterior chest. This is the upper zone in the anterior chest. And what you can see a sort of a wobbly kind of movement. The pleural sliding, I can hardly convince myself that there is pleural sliding, and it's almost as if it's dipping in, being pulled in by something, okay, rather than expanding up and down. As you go, now here in this particular image, maybe there is a little bit of sliding, but I'm really not convinced. Also, I'm not convinced that there is any pleural effusion. But if you look carefully, especially here, you can see that you can see some hepatized lung tissue in this area. So I think there is some hepatization of the lung with very little pleural sliding as a result of that. And when you come to the right anterior upper zone, so this is the right side near the clavicle anteriorly, you have a normal A-line pattern with pleural sliding, but there's not much expansion at all of the lung. And as you put an M mode, you can actually see the extent to which it's almost, this is a seashore sign, which is normal, but you see that's actually not particularly grainy like a good expansion. When you go to the right base, all the way down to the right base, you can see a lot of extravascular lung water. Okay. So again, this patient, I think what's happened with this patient is that there is a lot of collapse associated with the rib fractures on both sides, which has resulted in very minimal chest expansion and extravascular lung water associated with the atelectasis. Now, this patient is interesting because it shows two things. One, it showcases both the advantage of ultrasound or the strength of ultrasound, but it also showcases a fallacy of ultrasound, which is the operator dependence. Now, this 45-year-old patient had an opacity on the chest X-ray, and as you can imagine, there's a wide range of differentials. The radiologist thinks that there's a meniscus sign here, therefore there is a large pleural effusion with possible collapse or consolidation of the underlying right lower lobe. They've done a sonography, a lung ultrasound. This is the anterior chest in the midclavicular line, and what they have reported this as is that there is collapse. But what they've actually seen is this is the liver, this large structure here, occupying the entire field of view, is the liver. And if you can see, the liver is actually in the subcostal area. So you can see the rib shadows here. So rib, rib, rib. So there are 3 ribs. So you can see 2 intercostal spaces. And normally under the rib, you should be able to see lung. But instead of that, you're seeing an abdominal structure. So what's happened is that the abdominal structures have actually been pulled up, cephalad, into the subcostal area. And the sonographer has not recognized this. What they should have done is that they should have kept moving the probe 1 interspace by 1 interspace in a superior cephalad direction till they have they see the diaphragm and the curtain sign. So they've got an abdominal ultrasound in the thorax, and they have not recognized that this is actually a sign of significant loss of lung volume as a result of atelectasis. Now, the same thing happens in the right base. Once again, in the right base, what the sonographer has thought is that this is a pleural effusion and this is collapsed lung. Okay, but what they have not realized is that this thing here, this structure here is the kidney. Okay, this structure here is the kidney. This is the liver. And the reason I was suspicious that this is the liver is because if you look carefully, you can actually see echoes. You cannot, if it's a pleural effusion, it should be absolutely black. Or even if it's a complex inflammatory pleural effusion, you will have strands. This is a homogeneous pattern in the liver. Okay, so this thing here is actually the liver and the kidney. And this is possibly this structure here, this curvilinear structure here and here. This is the diaphragm. And superior to the diaphragm, you can hardly see anything in this. The field of view has not included the thorax. But I can reasonably confidently say that there's not much of a pleural effusion superior to the diaphragm. But what the sonographer has not done is explore this further. Again, what they should have done is recognize that these are abdominal structures coming in the thorax. They should have swept the probe slowly, 1 interspace by 1 interspace. They should have gone cephalad till they get the curtain sign. Okay. So now this is another case study of a 79-year-old man with dyspnea, and the chest X-ray was reported in the morning by the radiologist as right, mid, and lower zone consolidation. And it says that the left side is clear. Let's see what the lung ultrasound shows. And the lung ultrasound on the right side, now this is the right mid-axillary lower zone. This is the right mid-axillary upper zone, so in the flank. So, and you can see that there is lung water. You have thick B lines. It's a B line pattern. And that's also there in the right base. So the entire right lower zone, the mid zone, both anteriorly and in the flanks, there's extravascular lung water. And curiously, I can't see any evidence of consolidation or collapse on this. So I'd say that this is, depending on what we find on the left side, it is some form of interstitial syndrome, and early pneumonia cannot be excluded. So when you go to the left lung, what you notice first is that just near the heart, you have some evidence of air bronchograms. But also when you scan the left mid-axillary lower zone, so this is in the flank, this is actually the base, because you can see the curtain sign with the spleen coming. You actually have quite a lot of dependent B-line pattern, which you can't really see on the chest X-ray here. Okay, so there might be evidence of a dependent edema on both sides, and perhaps even some evidence of retrocardiac or lingular consolidation. So this might be a bilateral pneumonic process with the dependent edema either because of fluid overload, or it could be because of the inflammatory edema associated with the pneumonia. But what it really illustrates is how much more sensitive lung ultrasound is in comparison with a chest X-ray. This is a very interesting study. This is in a 64-year-old man with ARDS. I'm going to leave you to analyze this chest X-ray, interpret this chest X-ray, and then we'll move on to the lung ultrasound and we'll come back to the chest X-ray after that. Okay, let's move on to the lung ultrasound now. Now let's go to the lung ultrasound. First we'll do the right side. Okay. Now these three images here are all from the left anterior upper zone. This is the deep view, this is the superficial view, and this is the M mode. But let's first go to the left anterior lower zone, and what you'll find is you can see at least two intercostal spaces in the beginning of the third, and in all three spaces you can clearly see B-line pattern and you can see pleural sliding. In contrast, let's go to the zoomed up view of the left anterior upper zone. Look at the pleura very carefully. Is the pleura sliding? Look at it very carefully. Now compare it to this. Here you have the clear ants marching appearance, whereas here all that is happening is that the pleura is moving, but it's not sliding, and there's a big difference between the two. Now when the pleura moves, it can be because it's being pulled along by other structures, and if you look at the accessory muscles here, clearly the accessory muscles are active, and what that's doing is it's just pulling the tethered pleura from one side to the other, and the pleura is actually not expanding. Pleural sliding is absent, and if you put an M mode here, you can clearly see a barcode sign. Okay, now is this because the patient's respiratory rate is slow? No, because you can see here that the patient's pleural sliding is brilliant, and it's actually the B lines are moving fast. So it's clearly the patient is not having any hypopnea or apnea. Okay, so this is a true phenomenon. The barcode sign or the stratosphere sign is a true phenomenon. Now what is this? Is this a lung pulse? I don't think so. The only way I can confidently say this is in real time. You'll have to actually get at least a few cycles in order to see whether the cardiac pulsations are present. Having seen the real thing, and here I can hardly, there's only one cardiac cycle that's been recorded, one or two cardiac cycles that are recorded, so I can't really prove it to you, but I can assure you that at the time I did it, I looked for a number of cycles, and this pattern was not related to the heart, it was actually related to what the patient was doing. Okay, now every now and then the pleura would just move away and it would cause this sort of a picture. So this was actually an example of a pleural sliding. Of an absence of pleural sliding. And we'll go back, if you look very carefully at the chest X-ray, there's actually a very small left-sided pneumothorax despite the presence of the apical pleural catheter. Now, this is the right side, okay? And I'm only giving you one zone, which is the right anterior upper zone near the clavicle, and this is the 2D, and here is the M mode. And on the 2D, what you can find is that, see here, there appears to be clear pleural sliding, but see here, in the next intercostal space, there's virtually nothing. This is a classic example of a 2D example of a lung point, and that's confirmed on the M mode. Okay, so this here, can you see here, this is a stratosphere sign, and then here you have a seashore appearance, and once again here you have a seashore appearance. So this is a classical example of a lung point. Now is chest X-ray. You will see this. Okay, you can clearly see this is the lung edge here, and you can clearly see the apical. In fact, you have a large pneumothorax. You can clearly see a pneumothorax here. And if you look very carefully, and it's actually very difficult to appreciate on the X-ray, and that's why the lung ultrasound is much better. You can actually see a pneumothorax, but I'd find it very difficult to appreciate this. One of the take-home messages from this is that when you do a central line, always do an ultrasound before and after the central line, because if there was a good pleural sliding before the central line insertion and an absence of a pleural sliding after the CVC goes in, you have your diagnosis. So thank you. If you have any clarifications, I'd be more than happy to answer them. My email address is rrarvind@hotmail.com. Have fun learning lung ultrasound. It's a fantastic modality, and see you in the future. Bye.